Ok, Murilo?
Ok, doutor.
Ok, muito bom dia, pessoal. Nós estamos aqui em mais um webinar da Sociedade de Ombro e Cotovelo Regional Norte e Nordeste, com pleno e total apoio da SBCOC, da SBCOC e da Sociedade Latino-Americana e também do board com os nossos queridos representantes brasileiros aí. Antes da gente começar, a gente vai rodar um videozinho bem rápido do nosso patrocinador, a Zimmer. Obrigado, Leonardo, pela parceria. E aí a gente vai rodar um videozinho de 30 segundos.
Beleza.
Muito bem, uma coisa rápida, só para fazer a lembrança dos produtos do nosso parceiro. E Bernd and Mark, everything okay?
Yes, Mark is just loading up some slides on the tail end of mine. It looks like just a minute.
Okay.
Or less.
So I would like to thank you both to stay with us. It's a real honor to have you here. It's never much to register that the Morrey family is the most renowned family in the field of elbow surgery worldwide. Hundreds of surgeons around the world have learned with these guys, their teachings. I'm blessed to be one of them. From the bottom of our hearts, thank you very much for donating a little bit of your time today with us, Professor Morrey and my friend Mark. First of all, I would like to ask Dr. Gleidson Godinho, our president of the Orthopedic Society, to say some words for us. Please, Professor.
Ok. Bom dia a todos. Primeiramente, meu agradecimento em nome da Sociedade Brasileira de Ortopedia, como seu presidente, e me sinto pessoalmente extremamente honrado e feliz pelo carinho que vocês têm para comigo, pessoa física, e feliz pelo apoio que vocês dão à SBCOC, a nossa diretoria, a qual Alberto, que faz parte como vice-presidente, que também já está no coração de vocês aí a vida inteira. Vocês são cria dele também, né? Ele estará apoiando vocês em nome da sociedade. Muito obrigado, Roberto Ikemoto, meu querido amigo, companheiro, pelo prestígio de sempre. Luiz Alfredo, obrigado a você pela forma respeitosa, carinhosa com que você sempre me trata. Uma palavra, por favor, ao doutor, à família Morrey. Dr. Bernard and Mark Morrey, it's a great honor for the Brazilian Shoulder and Elbow Surgery Society and consequently for the Brazilian Society of Orthopedic and Traumatology to have the online presence of these emblematic names of the modern shoulder and elbow surgery, the Morrey family. Thank you very much on behalf of Brazilian orthopedists. Thank you.
Great.
Thank you. Thanks very much for the introduction, and particularly thank you for your very kind words and for the invitation to share a few minutes with you all and your colleagues. Can you see my first slide, my introductory slide?
I think I need to thank Dr. Roberto Ikemoto, our Brazilian president of Shoulder and Elbow Society, and
Oh,
Dr.
okay. Sorry.
Adalberto
Yeah.
from the Latin American Society too, and of course, Osvandre Lek, our president of the board of surgery. Please, Ikemoto.
Bom dia a todos, muito bem-vindos a esse web meeting da SBCOC, Regional Norte e Nordeste. Eu queria agradecer o convite para dar abertura de mais esse evento da Regional e parabenizo pela iniciativa de vocês e o trabalho que vocês vêm desenvolvendo. Toda a nossa sociedade de ombro e cotovelo é extremamente grata pela sua contribuição na educação continuada, trazendo conhecimento e atualização para todos os nossos associados. Agradeço também o apoio da Zime Biomet, patrocinar desse encontro e todos nós sabemos da dificuldade que a sociedade e as empresas vêm encontrando nesse ano de pandemia. Gostaria de lembrar a todos também que na próxima quarta-feira nós vamos ter um Cadáver Lab ao vivo, tá? E hoje é a data limite para o cadastramento. Vai ser transferência muscular e prótese reversa. Dr. Bernard, Mark, can you hear me?
Yes, yes, we can.
Oh, on behalf of Brazilian Shoulder and Elbow Society, we would like to thank you to join with us. One thing that the outbreak brought us is the reduced distance between people. So we have the opportunity like that link with both of you and learn about this difficult problem in the elbow. Thanks again, and let's continue.
Thank you.
Thank you. Now I would like to ask for Dr. Adalberto Visco, our Latin American Shoulder and Elbow Society President.
Bom dia a todos. É um prazer muito grande para mim, que sou daqui da região Norte-Nordeste, e fundei, juntamente com Saulo e Glauco, essa regional do Norte-Nordeste, Sociedade Brasileira, ver o crescimento dela. Parabenizar a Luiz, a Fábio, a João Felipe, que desenvolveram um programa esse ano espetacular de educação continuada na área de ombro e cotovelo. E, no momento, dando esse presente a gente da família Morrey, que realmente o Dr. Morrey foi uma das pessoas que modificaram o estudo da patologia do cotovelo. Eu só tenho a agradecer em nome meu, pessoal, como o Gleidson falou, também sempre pelo carinho que sou tratado por todos os membros da Sociedade Brasileira, especialmente a Norte e Nordeste, que é a nossa casa. Muito obrigado a todos e parabéns por esse evento. And Dr. Morrey, thank you for you and Mark for accepting this invitation. Dr. Morrey, Dr. Berna is someone that gave another dimension for the shoulder or elbow pathologists. Thank you. Welcome for name the Latin American Society. Thank you.
And finally, our friend Osvandre Lek, please.
The Chief Master.
My old friend, Bernard Morrey, my new friend, Mark Morrey. You are showing us legacy because both of you have been working and modifying the concepts in elbow surgery in these past decades. And this means a lot to us. I learned elbow surgery through your concepts. You have put your feet in every classification, in every new tool, in every new physical sign, and most of all, you put together the international community traveling abroad. I was in the room, Dr. Morrey, when you first came to Brazil, 1986, at the University of São Paulo with Professor Arnaldo Amado Ferreira Filho. You remember well?
Yes, I do.
I will send you the picture with you examining a patient in those days. And I remember well sitting and having dinner with Mark a few months ago in our meetings. So this legacy means a lot to us. thanks for your time, and congratulations for your legacy. That is a great example of life for all of us. Goodbye.
Thank you, Sander.
Thank you, Oswaldo. Please, Professor.
Well, thank you very much for the kind comments, and it's a very warm feeling for Mark and I to be discussing this topic or any topic, because we feel as though we're among friends. Our paths have crossed many times over the years, and we very much appreciate the courtesy of asking us, and also the kind words about the impact that some of our efforts have had. In this light, we would like to develop the theme that we have realized is very difficult, and that is the problem elbow in a young patient. When you can't just plan to put in an artificial elbow, there's other features. So this is a common question that we get, and we thought it would be worthwhile sharing this with you and your colleagues. So with that, of course, many of you have been to the United States and to Mayo, but I'd like to do a little travelogue of our campus. When we came to Rochester 40 some odd years ago, it's a population of 40,000. Now it's only 106,000, but this was the skyline back then. The dominant feature of the skyline, of course, is the Mayo Clinic, as you would understand. And I think many of you would realize that as an academic institution, there's three main features to the mission. The large shield in the middle is the clinical practice, and it's supported by research and education, which is true really of all academic institutions. This is one of the research buildings where we did a lot of the biomechanics work, the early work on the elbow. These are two of our educational buildings. The one on the left was the home of William Mayo, and he hosted many, many visitors from all over the world, and it was really the key concept of educating and sharing your ideas. And that concept is being expressed even today as I speak. The building on the right is the administrative educational building, but the key to the clinic is the clinic. And these are the two of the buildings that are kind of the iconic Mayo Clinic buildings. This is the trauma hospital, and where I spent most of my early years in training. And then this is more the reconstructive, the cold surgery hospital, Methodist Hospital. Today we have an additional clinic other than the Ivory Tower, as it was called, and orthopedics occupies all of one floor and half of another floor of this structure. So we're very fortunate to have excellent facilities, but the most important thing that we have at Mayo is the legacy of the Mayos, and this was what we were told.
Sorry, Professor, Dr.
Yes.
Morrey.
Yes.
The slide is not going on.
Are you not seeing any slides?
No.
Oh my God. That. Well, just put it anywhere. See if it comes. Can you see that?
Slides?
Yes.
You see the
Okay.
slide there?
Yes.
Yes, doctor.
All right, well, I'll get my whole talk from this one slide. That's just a joke, of course. Let me see if I can. There it goes. Okay, so here's those slides that I was running through were the buildings of the Mayo Clinic. And this is the theme that we all know and try to follow in our professional lives, and is really the basis of much of the work that we've done in Rochester. So we'll develop the idea. We'll try to keep it simple and logical. So there's three basic diagnoses that you think of in the young patient, And then there's three basic opportunities for intervention, surgical intervention. And so we will work the theme of the three diagnoses and the three primary modes of intervention in the context of what we call first principles. There's a few things we think about and we try to follow with all of our considerations for these patients. And we'll go through the diagnoses according to indications and key considerations, technical points, and then share the results. And hopefully it'll be pretty logical and not disorganized. The first principles that are not complex, but they're things that we have come to learn over the years is you got to do the right operation first. And that means, for example, in a bad C3 fracture, if it can't be fixed, then it's better to replace it. Now, ideally, you want the patient to be older, and fortunately, most of those patients are. If you don't do the right operation first, and we'll talk about this later, the second operation to salvage the first one is never better than the first chance you had. You should always also consider, of course, if this doesn't work, what would you do next? What is the next opportunity or the next option? Then for us, and I think it's probably a wise thing, is always consider the artificial replacement. You're violating the canals. Always consider it a salvage procedure, even if it's the first operation you're doing. So as we look at the various causes of arthritis, particularly in the young, primary osteoarthritis and post-traumatic are the two most common non-inflammatory. And the non-infectious inflammatory processes are numerous. But of course, we all know most of them is an autoimmune rheumatoid arthritis. We also know that's always is now being modified with the DMARDs. So as we look at the options for treatment, theoretically, there's five: debridement, arthroscopy, interposition, replacement, fusion, and resection. But we don't accept fusion and resection because those aren't really functional. These are more salvage, and they're almost always just used for the infected elbow. So there's really just the three, and those are the three we'll be talking about. As we look at this array then, the way we kind of think of it is for primary osteoarthritis, it's a debridement procedure. We rarely replace those elbows. Occasionally, we'll do an interposition. For the post-trauma, the ideal in the young patient under 60 is an interposition arthroplasty if we're dealing with the effects of a traumatic elbow, and those may be in the younger working patient. If that doesn't work, or if that's not available or ideal, then we do replace those elbows, of course. Finally, for inflammatory, the ideal procedure for an inflammatory elbow is the total elbow, even in the younger patient. But we have quite a bit of experience with interposition in the very, very young patient. But you can think of the three primary etiologies as having each its own kind of specific ideal intervention, as we see here. So Mark will now talk about primary osteoarthritis and emphasize the technical aspects of the debridement with the scope. He'll then talk about the post-trauma and talk about technical features of interposition. And then I will close by talking about inflammatory etiologies as well as post-trauma etiology and the role of total elbow. So that's the way we will develop this. And so with that, I'll let Mark take it from here.
Everybody, can you see the screen, Luis?
Yes, yes.
So I'll be talking about the arthroscopy for really the younger patient, and this is primary osteoarthritis, as my dad alluded to. And your goal of treatment, really the goal of any treatment, is to restore the function, relieve the pain, and do this safely. And when you're doing this arthroscopically, it's all about the nerves. They're very close to the elbow, and so in order to manage the nerves, you have to have good fluid management, decreasing the pressure, understanding how to recover portals, placing retractors so you don't have to run pressure too high, and not using suction around the elbow to avoid sucking in a nerve. And then it's down to practice. It's like anything else that you want to get good at, a sport. Soccer's pretty big in Brazil. Those professionals didn't get that way without practice. So when you're first learning this, you start small and then you work up, and we're going to be talking about primary osteoarthritis, which is toward the bottom in terms of its complexity because it involves lots of those technical points. So I'm hoping that this will work. If it doesn't, I'm going to try to load it from my Dropbox. So just bear with me for just a second because that one was not working. Yeah, it's no, that is the talk. That's what I spent the time on. Ah. Okay. Can you see the screen?
Yes.
Okay, so it'll work. This is the patient. So this is a young patient. You can see the range of motion is quite limited, particularly in extension. She was having trouble actually getting her hand to her mouth as well. And this is really functionally disabling for patients, young patients. And this is a marginal disease. So the osteophytes are along the margins of the joint. Oftentimes the cartilage is spared. And so when you're doing this, the planning is important because you want to remove the osteophytes where they are, limiting the motion and not other places. So this is the typical outline of how I'm doing my planning. I want to remove the osteophytes from the posterior aspect of the olecranon and then the olecranon fossa to deepen that for extension, along with the capsule in the front. And there you see a view of where the margins are. And then in the front, it's not unusual to see loose bodies, loose pieces that have broken off, but also deepening the fossas. Here's a cutaway view of an anatomic specimen, which shows where those osteophytes live in the fossas, in the front and the back. And when you're trying to gain flexion, you remove the osteophytes in the front, the capsule in the back. And when you're trying to gain extension, it's the capsule in the front and the osteophytes in the back. So this is what you're removing. And I use a burr as sort of my measurement tool. It's a 5 millimeter burr, so I know what my depth is to establish that as a reference. So here's again, this is a specimen that we 3D printed. 3D printing has really helped us to understand that you don't need to remove everything to get the motion, but you need, and that's safer to not do that, but you need to get the stuff that's impinging. And here you see a quite extensive osteophytes, and you can see the limitation in the motion and flexion and extension where those blocks to motion will be. In the primary osteoarthritic patient, typically the capsule isn't as stiff, and once the bone work is done, the patients will gain significant amount of motion without having to release the capsule, which is safer because then you don't have to worry about the nerves. I'm gonna try to mute that. So this is just a sped up film of taking off those osteophytes, and this is how I learned to do this procedure on 3D printed models. And there you can see you can gain significant extension with just a few of the osteophytes being removed. And then in the front, deepening the fossas, connecting the fossas, and then you can see how much range of motion you can get and where you need to work in order to remove the remaining osteophytes to gain motion. So once you're satisfied with your plan, then it's a matter of executing that. And it would be nice if it was as easy as this sawbones or this 3D printed model. But unfortunately, we have to worry about the nerves and getting in and establishing a view. So typically, this is the setup for arthroscopy. If there was fracture work or other things that needed to be done, you can see you can easily bring in a C-arm and still scope. You want to make sure that the antecubital fossa is clear so that you can flex the elbow and assess for range of motion. The patient's in the lateral decubitus position here, and I mark out the ulnar nerve and the radiocapitellar joint. And then it's establishing the portal. So this patient's on the side on an arm holder. You see the posterior arthroscopic portals. The first thing that we do is we distend the capsule. And this is it's like a balloon. If it's floppy, it's harder to poke in. But if you distend the elbow, and that's typically around 30 cc's of fluid, then the balloon tightens and you can pop in. And this does a lot to increase your working space so that your nerves aren't right up against the articulation. But it does nothing to the relationship of the nerve to the capsule. So the nerve to the capsule remains the same, but now you can increase your working space inside the capsule. So that's why we distend the elbow. So you get in and you establish your view. I start with the proximal anterior medial portal. That's about 2 centimeters proximal and 2 centimeters anterior. But really it's a palpation. You can palpate the column and directly enter against the humerus and then angle back toward the radius and pop through. So this is how we do that. I'm feeling the septum, feeling the anterior part of the humerus, and then the needle is at the posterior lateral soft spot. And then that helps us to stay well posterior to the median nerve. Then we just unclip that for our outflow portal. When we start, arrange the scope so that I'm looking at the capsule, and there you can see the view you get. You confirm with the little rotation of the radial head. And this is the area that you're gonna be looking at in order to establish the next portal. So you can back your scope up. You can see the fat within the fossa. It moves away from and out of the fossa. And then we use an outside-in technique to introduce the lateral portal. The radial nerve is at the equator of the radial head, so it's directly anterior if you draw a circle. And I use the needle to see if I can have my trajectory to do the work that I need to do. So we established that the outside-in portal through a needle and then a knife technique. So once we know our trajectory, we can use the knife then to open up the capsule. And occasionally I'll use the knife actually to strip along the supracondylar ridges to gain even more motion for the instruments. But here you see about the location where you're entering, and the further anterior you go, the more dangerous it is to the radial nerve, which is outlined in the arrow. The further distal also, the more dangerous it is for the radial nerve. So a really good understanding of the arthroscopic anatomy is necessary. The further posterior you go along the capitellum, is where the ligament is at risk. So you want to avoid instability posteriorly, and you want to avoid the nerve anteriorly. Then once you get in, you just kind of clean up that, that fat from the fat pad, and that's attached to the capsule. And the next step is really to make a space. So this is a release along the supracondylar ridge of that capsule. And then I use a switching stick, and you can see the switching stick can be a very effective retractor. So you can see the entire articulation and where you need to do your work. Now in this video, the humerus is straight up and down, and the forearm is pointing off to the left of the screen. So I'm coming across the front of the elbow. There's a very tight band in the anterior aspect of the elbow with the capsule, and that's where the retractor is really useful. So that retractor is established proximal to your viewing portal or to your working portal on the lateral side. And it's important to be able to switch around. We do this with a switching stick technique where you just uncouple the scope and then drive the switching stick through the cannula, and then you can really quickly and safely switch the camera around. It's really, really important to be able to do this efficiently, because if you lose the portal, you spend a lot of time trying to reestablish it while the elbow is swelling. So these types of portal switching techniques are super effective, super fast, and make it efficient. And there you can see the view to cross to the medial side. I always register myself with that switching stick to make sure that I understand what my orientation is. Again, you're working upside down and backwards, and so just feeling with the switching stick is helpful. And then again, we remove the fat pad from the medial side, establish a switching stick on the medial side for a retractor, and just establish a place where you can then do the work. And then once you have an effective space, then you can start to remove the osteophytes in the fossa. So here is the working toward the medial side and deepening the fossa on the medial side. And then you see that ridge in between the radial fossa and the coronoid fossa. And I oftentimes will just take that ridge down. It's not structurally important, and it'll allow you to work all the way across to the lateral side. So again, I'll use a 5mm burr. You can easily instrument with an osteotome to take out osteophytes off the coronoid. And there you see the coronoid coming into view, and you can assess your impingement by moving it. So this is back to the original patient that I showed earlier with a large loose body. We just take off the fibrous tissue with a cautery wand. And then once it's fairly mobile, you can grab that with a grasper and pull it out. You don't want to release the whole thing, otherwise it'll just float around and it'll be hard to find. But there you see the osteophyte removed, the radial head in the distance, establishing a portal site for a retractor. And then you can see the view that you can get all the way across the elbow to be able to do the work. And then this is after some of the bony resection has been done and the fossa has been deepened. And then the last step is really to remove the capsule and to work in the posterior aspect of the elbow for the osteophytes. And for there, it's really important that you just avoid the ulnar nerve. So you can feel where the triceps is. I go just lateral to the thick portion of the triceps, right directly down into the fossa. You can make any number of portals along the lateral side posteriorly, because that's safe. And then once you get in and establish your viewing portal from the posterior lateral side, then you can work to, as my dad taught me, you eat your way into the joint. There's the fat pad, and this is oftentimes fibrotic. So you want to remove all of the tissue that's within the fossa, and sometimes that takes a little bit of time, but you want to remove it until you can see. And some people ask, well, how much can you remove? Well, you got 3 to 8 millimeters before you start to take down the triceps. So that was a study by Raul Barco. So from the arthroscopic side, if you remove the capsule, you've got about 8 millimeters before you're in trouble. And then this is the really dangerous part, which is the posterior medial viewing portal. And I don't do a lot of nerve releases. I think it's dangerous. If I'm going to do a nerve release in somebody who's really stiff, then I do that open through a mini open approach. And the reason is I'm not decompressing the nerve from the inside. There's still a tight band. Sometimes there's an osteophyte that you need to remove, as I've done here, or a loose body that you can find, and you can grab those safely and remove those. And that's what that looks like at the end. But to do the nerve work, I'm going to do that through an open approach so that I can release it, because you can see how close you are to it from the arthroscopic portal. Here's that tight anterior band in the front. You can see how it comes so far down in between the radial and cornoid fossas. And if you use a switching stick, you can oftentimes strip the capsule anteriorly in order to do your last step, which is a bite and peel technique to remove the capsule, and then the procedure is done. So your goal again is to gain motion, and if you do those steps and practice with those steps, you can be effective in releasing a capsule in primary osteoarthritis quite effectively. So what happens when that fails? And can you still see the screen, Luis?
Yes, perfect.
Is it interposition arthroplasty? Is that the next one that's up?
Okay.
Can you see interposition arthroplasty?
Yes. Full screen. Okay.
It's okay? Okay, great. So when would you do this? So let's say the scope fails and you've done your debridement and that doesn't work anymore. Well, in the primary osteoarthritic patient, occasionally the joint surface will hurt the patient through a mid-arc of motion. And then you may consider interposition arthroplasty in those patients. But again, to go harken back to what my dad said earlier, most of the patients that are going to require an interposition arthroplasty are for the sequela of trauma. So their joint surface is both incongruent and unstable typically, and it's arthritic, and the joint itself is painful. And when the joint itself is painful, that's when we consider interposition arthroplasty. So just to remind everybody, for the etiology, the primary etiology for using the scope in the previous examples was primary osteoarthritis. It's removing the loose bodies, removing the osteophytes to gain motion, but they don't hurt through a mid-arc of motion. So it's impingement pain. It's the pain that you feel at the end range of motion. And those are perfect candidates for the scope. But patients that have pain through a mid-arc of motion, and that's typically the post-traumatic patient, those are patients that we are indicating for interposition arthroplasty most commonly. So why would you interpose? Well, typically there's less restriction. So when we think about a total elbow arthroplasty, you're going to give that patient a restriction lifetime of lifting about a gallon of milk at any one go and 2 pounds repetitively. At least that's what we say to protect that implant. But we don't have those types of restrictions for interposition. So it's much less restrictive, and that's oftentimes more palatable in a post-traumatic patient. It reserves our future salvage options, which, you know, in these patients, this is already a salvage. So it reserves the salvage of the salvage, which is even a more difficult problem in general. There's no hardware. That you are putting in a graft, but there's no hardware other than sutures. There's less of a chance for bacteria to gain a foothold. And you can do this on the lateral side, or you can do an entire ulnohumeral, and I'm going to talk about the ulnohumeral. There is typically a little bit less motion. It's still functional motion. Our arc of motion is around 100 degrees when we do these. There may be a little bit less pain relief, but acceptable for patients, and it's a little bit technically more demanding. So this is an example. I do the case example to illustrate the points of interposition, and this is an excavator operator. He is a heavy manual labor, and he's also a farmer, and he comes to the office and says, well, I don't want that replacement thingy. So this is a perfect patient, a young patient who would benefit from an interposition with pain through mid-arc. This is a 42-year-old police officer this is a 20-year follow-up after her interposition arthroplasty, and she can do 30 push-ups in a minute, even though the x-ray looks horrible, she's still working. And when you're thinking about a 22-year-old doing a total elbow arthroplasty or this, I would I would suggest that we do this first. So what's the essential questions? What does the patient want? Pain relief? Do they want motion? Is it a stability problem? What are their activities? And then what is the salvage of that salvage procedure that you're going to do? So the first option is interposition arthroplasty, and Dr. Larson and my father looked those patients up. And then the next option to that is, well, what happens if the interposition fails and the patient's still young? Well, you can revise that. It's not quite as good as the primary, but you can do an interposition of an interposition. And those patients, that's about 50-50, will get about 5 or 6 additional years. We've got plenty of examples of those patients. And then the next option after that would be total elbow arthroplasty. And Blaine looked up our total elbow arthroplasty after interposition back in 2005, and I'll be updating that series shortly. And the risks to those patients aren't any greater than doing the primary total elbow arthroplasty, which is really, really important. And there are multiple studies on the outcomes of total elbow arthroplasty. But what happens when that fails? Well, then you go to revision total elbow arthroplasty, and there's much less written about that. What happens when that fails? Well, then you go to the revision of the revision, and there's even less about that. So when we look at our overall experience for over 40 years, about 25% have had to come to revision. And you see the reasons for that. But things have changed over the decades. And when you look at this graph, you look at around the early decade, right, 2000s is where we really started to approach an inflection point between inflammatory arthritis and post-traumatic arthritis. You can see we weren't doing total elbows for primary OA very often, less than 1% in our series. But for those post-traumatics, that is the #1 indication now. It's traumatic conditions. That surpassed inflammatory arthritis right around 2000. So what is the risk of the revision then? Well, it's pretty high. It's 10 to 20% at 10 years. And when you look at these follow-ups for revision arthroplasty, you can see that they're really short follow-ups. So 3 years, 2 years, 5 years, 4 years, 7 years. And that's not a very long time when you're looking at a really, really young patient that is going to have another revision. This is the only article right now that actually looks at the survival curve of revision or the time to revision. And you can see, it's about 50-50 at 7 years, which isn't great when you're thinking about putting in a total elbow arthroplasty in somebody who's in their 40s. So, and then again, this is really short-term data, and these are allograft prosthetic composites. So these are heroic salvage operations at a revision with really short-term follow-up. So you can only fold that piece of paper so many times before you run out of paper. And what would you rather revise? Would you rather revise the total elbow arthroplasty on the left to another total elbow arthroplasty, because that's the only option? Or would you rather revise an interposition arthroplasty after 20 years of good use from that patient? So it's a salvage, and it's a salvage of a salvage, and sometimes a salvage of a salvage of a salvage of a salvage. This is a patient that Carlos Ramos showed me when we were in Bogris together. So you only have so many attempts, and I would say that you're a little further up the train track when you start with interposition before you're actually going to fall off the edge. So avoid the seductive temptress in the young patient for total elbow. So when and who would you do an interposition for? Well, we've been talking a lot about their age and demands and whether or not they have pain through a mid-arc of motion. Those are the critical determinants. And if you can make that joint stable. So that's the third point that is really, really important. Is that joint stable now, or can you make it stable? And if those two things exist, then you can do an ulnohumeral interposition. This is an example of a patient with Larson grade 5 rheumatoid arthritis that I can't make this elbow stable. So this is a patient who's going to get a total elbow arthroplasty in my hands because that is an unstable elbow. But this is a patient, a young guy who is a manual laborer, and if I can make that elbow stable, an interposition is better for him. And this is a case that my dad and I did together where we had to osteotomize, deepen his ulna, and then do an interposition with a ligament reconstruction. and that stabilized his elbow, and he's still working as an excavator operator. So when you look at the historical results of interposition, how do they fail? Instability. 20% failure rate due to instability. Poor outcomes with instability. Poor results with instability. No matter what article you read or anything in the literature, it's always failure because of instability. Patients are generally satisfied in terms of their pain relief and their arc of motion. And when you look at the pre-op arc of motion from our studies at Mayo, from 53 to 98 to 31 to 117, that's an overall arc of about 100 degrees. And importantly, 85% of those patients were satisfied. They would have that surgery again. And in a young patient, that's really, really the most important question, maybe the only question to answer. And then here is our revision of the interposition. How do they do immediately after? It's about a 50-50 proposition in those patients. And again, stability is the key, so you need to reconstruct those ligaments. And back to our 54-year-old laborer, I don't want that replacement thingy. This is how we do it. And for that, I will hopefully be able to show you the video, so I'm going to do that now. Please let me know if you cannot see the
It's okay. We are seeing.
I apologize for all the switching around. It's for some reason, it's just not working on one computer.
Don't worry about it.
Can you see the screen still?
Yes.
Okay, great. So we start by identifying the ulnar nerve and releasing the ulnar nerve. And we had a higher rate of patients when we dislocate the elbow of actually hurting the nerve. And so this is, we find and identify it and protect it through the procedure. And that's something that we found when we looked up the early results, was that they had a lot of nerve problems. So we release the nerve and protect it. And then we go back to the lateral side, and this is an interval. It's a very safe dissection to work underneath the anconeus and keep the anconeus in line or in continuity with the triceps. And we just use a periosteal elevator to elevate the anconeus from the ulna. So the forearm is to the right, the humerus is to the left. And we elevate that as a single sleeve, and there you can see the joint, releasing the capsule. And there's the olecranon. And then we're going to work in front and behind of the ligament. So here we're working anteriorly to dissect the ligament, and proximally to come down on the ligament from the proximal aspect. So this is really working in front of the humerus, and Kaplan's interval in the front and Coker's interval in the back. And you can see where the capsule is referable to the ligament. And these patients are stiff, so you can do a column procedure and resect the capsule, or capsulectomy. And then you identify the ligament from the front and the back, and then you can release it right off the humerus for later repair and also augmentation. And there you can see its attachment site on the ulna. And now you need to be able to dislocate the elbow. So you continue your dissection, and this is probably the hardest part to learn, which is you need to be able to reflect the triceps all the way until you can roll the triceps on itself to be able to dislocate the elbow. And so that's at the posterior lateral corner of the olecranon. You can see you can release it and maintain the bulk of it can remain intact, but you can now dislocate the elbow so you have access to the articular surface. And here's what we're using currently, which is an Achilles tendon graft. If you don't have those available, you can certainly use a fascia lata or dermis. We've just found that this has a bulky enough graft and heals pretty reliably to the articular surface. We use 3 drill holes when it's just when it's just the ulnohumeral joint, and 4 if we're coming all the way across to the lateral side. And that's the typical orientation of where the drill holes are going to come out and how you're going to try to wrap this. It's really important to have that graft opposed to the articular surface so that it'll heal. And it goes all the way out to the margins of the joint surface. And then we pass our sutures with a Keith needle. After we've tied those, we shuttle those back through to the posterior side. And you really want that graft tight up against the anterior portion of the humerus. And then this drill hole is going to come out very, very closely to where the ligament is going to attach so that you can stabilize the elbow or augment the stability at the end. And there you can see how it attaches to the front. And then we pass those sutures around through the Achilles tendon. And now it's opposed to the end of the surface. And when we reduce that elbow, you want a nice, smooth arc of motion. And then you can take a sleeve of the Achilles, which is why the Achilles is really nice, and you can augment your ligament repair or reconstruct in the setting that you need to do the reconstruction. And again, the stability is the key. So here you can see we bring up and repair that ligament, and then we can take the sleeve of the Achilles and augment that ligament repair so that the elbow remains stable. And here's back to the excavator operator. That's the ligament augmentation. And then an external fixer that can be placed to protect that repair while it's healing. And if you need to do both sides, you can connect the ligament insertions through a drill hole and pass those all the way through the ulna for a sling procedure. And that really stabilizes the elbow through the entire arc of motion. And that's really the technical sides of how we perform the interposition. And I'm going to turn it back over to the professor for the total elbow.
Nice. Okay.
Okay. So we've reviewed in some detail then the scope for primary, interposition for its best indication is post-trauma, but I would mention in this, and what we looked up, the outcome for a inflammatory patient was about the same as a trauma. So it's still a very good operation for a young inflammatory patient, and as you see in this kind of matrix form. So interposition is a good procedure for the young inflammatory, particularly if they don't want to have restrictions of a total elbow, and particularly if they're very, very young. So what we'll emphasize now are some of the features of the total elbow. And there are certain generic comments that we'll make regarding selecting the patient, selecting the implant, the technique, highlights of the technique, and then some specific information regarding indications, and then that'll be pretty much in general, not distinguishing between the post-trauma or the inflammatory patient. But then we will discuss the results with the stratification of a post-trauma result versus a result from an inflammatory process, rheumatoid arthritis. So first of all, selection, we talk about the young patient. Well, what's young? And we all know that it's a function of how active the person is and what their physiologic age is. And that's a very important consideration in any of these options, as Mark pointed out. One of the things that we all know is that what's the problem with the total elbow is it restricts your activity. We put limitations on you. And I should say we put limitations on ourselves and our minds because the patients really don't pay much attention. So this was a study done by one of our colleagues of 100 patients, and a little over half of them were primary, the other half were revisions. And 94% engaged in moderate activity, which means they didn't pay any attention to the restrictions. And 40% engaged in heavy activity, and they paid absolutely no attention to the restrictions. And why is that? Well, it's because they had very good pain relief, they didn't hurt, and they felt like they could do it, and so they did it. So we have to be aware that when we say we put the restrictions on the patients, excuse me, not too many of them pay very close attention. And interestingly enough, over half of them didn't even remember what the restrictions were, so they couldn't follow them very well. So their perception of compliance, when you said, did you follow what we told you? 80% said they did. So there's a real disconnect between what they do and what they think they're doing. Now, this is important because not too many people, we're trying to share ideas that people don't know. Obesity is a risk factor for the total elbow. Now, we know that it's a risk factor for BMIs of over, say, 35 for total hip or total knee. But one of our fellows looked this up a while back, and I thought he was wasting his time. He wanted to look up obesity, and I told him, don't you have something better to do? And he said, no, he wanted to look it up. So I said, okay. So he did, and I was surprised to find that patients that had a BMI of over 30 were 22% of our patients, which isn't too many really. But look at the statistical increase in loosening, mechanical failure, or failure for any reason. We're all statistically significant compared to a control of BMIs less with the same diagnoses. So just be aware of that when you're talking to a patient. You can't select your patients in that sense. If they've got a problem that needs a replacement, just let them know if they're obese that whatever you quote them as an anticipated outcome might not be true in their case. Well, over the years, we found certain characteristic features of the implant, and the implants that are being used in the United States and I think in most places now have these features. One of them is they tend to be linked. This allows you to address a whole spectrum of pathology. And they have a flange, and the flange is very important to resist posterior stress, and also, like you see in the middle, rotatory stress of this patient that's post-trauma, has no distal humerus, very nice mature bone graft, no evidence, this I think was a 12-year x-ray, no evidence at all of loosening of the implant. So this should be linked, loose hinge, and flanged are, I think, the essential features of the implant. Now, a common question has to do with the size of the implant. And so Gabor Apuskus, who was a partner of Christian Gerber, looked this up when he was doing his mini fellowship with us. And so he looked up the 4 and 6 inch implants, and the loosening rate was not statistically significant between the 4 and 6. So I interpreted that as saying it doesn't really matter. You can use a 4-inch stem in a post-traumatic case, for example. But I overlooked something, and I went back and read this actually just a few months ago, and I've kind of changed my opinion because the surveillance is longer in the 6-inch than the 4-inch for some reason. But the time to revision, even though the revisions were about the same rate, 4-inch and 6-inch, the time was statistically different. So that says the 6 inches last longer. So I do now think that it's wise, if you're going to do a post-trauma, I tend to select a 6-inch stem by you doing an inflammatory 4-inch stem. So in general, what are the issues of technique? One of the most common errors that I see people make is they don't appreciate nuances of the canal, particularly the bowing of the canal and the size of the canal. So that's very important preoperatively to have in your mind what you're dealing with in that particular patient. Today, we leave the triceps intact for virtually everybody, unless they have a lot of deformity. And in the earlier years, we left it on for the post-trauma. Now we leave it on for everybody, and I'll show the technique we use. There's some very important features of the cement technique. They're not complicated, they're just important. I have seen people put in a flanged implant and not bone graft behind the flange, and the flange is sitting in the breeze. That flange only works in your mind. It doesn't have any impact at all in that particular elbow because it's not engaged. So you have to make sure the flange is actively engaged and will incorporate into the bone. Rotatory orientation of the implants are important for any system that you use. And then for the trauma, the one thing that people do not appreciate necessarily is the potential to have soft tissue impingement causing loosening of the ulna. And I'll talk about that in a second. So today we use what's called the para-olecratin. It was been popularized by Graham King, and it's really a nice procedure. It's relatively fast and it's easy to close, and the patient had essentially normal triceps function. Distally, which is to the bottom of the screen, the interval is between the ankylus and the ulna, and then proximally it's just to the lateral margin of the central triceps slip. Once this interval is entered, we release the common flexors and extensors. The lateral side is released through the interval. The medial side is released directly from the medial side. Notice the triceps is the central slip, never gets violated. It stays intact. And then we roll the ulna off the humerus. You can either roll it off medially or laterally, but notice that you have access for ulnar preparation. And notice that triceps is still virtually completely attached because the central slip is attached. So this is a kind of a very, very elegant, I think, exposure. It's not the only way to leave the triceps on, but it's the way that we are preferring now. You should use an injector system. I've been to some places that didn't seem to have them, and I think it's a big mistake to try to do this by hand. Today, I think everybody recognizes that. It's also of great value to use a bone plug. And this, if nothing else, restricts the cement from going to the shoulder, particularly in an inflammatory that may need a shoulder replacement. But it also allows you to pressurize the cement and get a better interface. And then the rotation landmarks for the humerus are the posterior condyle surface, and it rotates off that just a little bit, but the condyle surface right around the olecranon fossa is pretty accurate to the flexing axis. On the ulna, it's perpendicular to the plane of the flat portion of the ulna. All our elbows more or less are flat right through this area here that you can see on the screen. And your flexion axis is perpendicular to that plane. And you can identify that with your rasp. So with that, let's talk a little bit about trauma. What are the indications? This is a very important idea. It's very simple, but it's important. When you lecture on this or think about this, it's important to realize, are the people you're talking to capable of doing either an ORIF or a replacement? If you're talking to trauma surgeons and they do ORIF, then they may not be capable or comfortable doing a prosthesis. Unlike for a hip fracture, where most trauma surgeons are comfortable putting in at least a bipolar. So it's very important to recognize that you should be able to go either way if you want to give the patient the best chance for a good outcome in an acute trauma. And so what are the considerations? As we talked about age and activity, of course, one of them that's really important is that fracture fixable. There are some fractures that you can spend 5 hours and you know at the end of the day, it may not heal, they may resorb because of all the fragments. It's going to be very stiff. There's chance for infection, nerve injury, the longer it's open, etc. And so there are some instances where actually the injury itself dictates, even in our younger patients, that they need to have a replacement. And then, as Mark said, you always have to think about the next operation and how do you salvage a failure? Is it easier to salvage a failed ORIF or compared to salvaging a failed total elbow? So with the trauma patient, as I already mentioned, in addition to the considerations I just mentioned, we do use the 6-inch implant. Notice this is a post-trauma patient. There's no distal humerus and a nice matured bone graft and a very, very quiet interface. Notice this stem is slightly bent because it's 6 inches and it would be approaching the posterior cortex. So pay attention to the medullary canals, particularly if you're using longer implants. Now, this is not generally appreciated, and it's really important. If you have a patient that has trauma, acute or let's say a non-union, there's no distal humerus, it's hard to know the landmark of how short this actually is. As you put a trial implant in and you flex the elbow, if you have place the implant too far proximally, the soft tissue will bunch up and serve as a fulcrum, and as the elbow flexes, the implant gets pulled out of the ulna. So one thing that we have found very helpful is we do a trial reduction, and then we pull on the forearm in 90 degrees and see where the implant sits with tension on the flexors and extensors at 90 degrees. We call it the shuck test. We're pulling it down, and then we mark that distance, and that's the depth of insertion of the implant. We've done studies. You don't have to have the implant all the way to the hilt of the flange. You need 2 centimeters of flange for the bone graft to be effective. And so in this setting, I would use a longer flange and pull the implant out so that we've got proper tensioning. So when the elbow flexes, the soft tissue does not serve as a fulcrum and pull the ulna out. It causes the ulna to loosen in tension. So what are the outcomes? Well, there's been quite a number of studies, and they are a little bit variable, but for the most part, very short follow-up. Notice only about 4 years, about 250 cases. The outcomes are really good, better than what you would expect in badly comminuted C3 fractures. And I think this is one of the most important studies in the elbow of any type. It's a prospective randomized study by Mike McGee in Canada. It was multi-center. I think they had 4 centers, and they did a comparison between ORIF and a total elbow. And notice the age, older age group, and 5 crossed over from the ORIF to the total elbow because they couldn't do an ORIF. It was too badly comminuted. So these 25 of the total elbow are the most complicated, more complicated than these, than the ORIF. And in any event, the follow-up was 2 years. The operative time was longer in the ORIF. The reoperations were twice as common in the ORIF, and the arc of motion was 10 degrees more with the elbow. So they concluded that in the older patient, total elbow is the treatment of choice. Now, that's not in the younger patient, that's in the older patient. And then this is, I think, another important study. Raul Barco, Samuel Antunes' partner from Madrid, looked up our 23-year results on the acute because, since, as Mark said, is the more common indication today is trauma for total elbow. It's important to understand what is the long-term outcome because people are putting them in younger and younger patients. In any event, there were 44 procedures with up to 23-year follow-up, and they all had more than 10 years, minimum of 10. And the average MEPS was 90, so it was still pretty good. But what was interesting is the survival curve. At 10 years, the trauma was better than the rheumatoid, and this part of this is because of infection. But 92 compared to 78. And then out at 15 years, the survival free of revision for post-trauma was still 85%. So that suggested that, at least in our experience, for whatever it means, it's a little different than what others are reporting because this is a little better follow-up, better survival free of revision than what others have quoted. Now, the one last thing I'll mention on the trauma is, again, the big theme is think about salvage. What happens if it fails? So the question is, if you get a bad fracture, can you try an ORIF? And if it fails, you can, quote, always do a total elbow. Is there a problem with that philosophy? And I think there is. So this is an example. This man was 90 years old, and he's had 3 operations now. And of course, that's not a very well thought out operation, as you would agree. That man should have had the total elbow when the fracture came in. So that the key is the treatment failure. If you have an ORIF and it fails, you can do an ORIF. These are, again, reserved for infection. You can do an interposition, as Mark showed, or you can bail out and do a prosthesis. If you do a prosthesis, your only revision is starting down that track, again, as Mark pointed out, of one revision after another, possibly. So we decided to look up our experience with patients who failed within the first year of an ORIF. There were 22 patients that met the criteria and were converted, and then we matched them to 50 patients that had an acute total elbow for fracture. And what we found was there was no difference in the MEPS or the outcome if you avoided a complication. However, in the group that had the ORIF fail and then converted to a total elbow, they had statistically significant more complications, more revisions and reoperations compared to the acute. So at least in our mind, it kind of reinforces the idea that do the right operation first in an acute fracture. The procedure of choice is a total elbow, particularly if it's not a very fixable fracture. Okay, so we'll close with the inflammatory. We'll only say a word or two about it, but we've talked about the other general features. For the inflammatory patient, total elbow, we still try to avoid it in the very young, but sometimes your hand is forced. And we also even avoid total elbow in the inflammatory if they're a little bit older but active. However, once it is indicated, it's a very good implant, very good option. We do typically use a 4-inch small humerus and small ulna. We leave the triceps on, as we mentioned. We pay attention to osteoporosis and thinning of the olecranon because that occurs in the inflammatory, and that can fracture if you're not careful during the procedure. And again, we try to select the patient who is compliant, and if they have multiple joints involved, then a joint replacement is ideal because they'll tend not to overuse it. The first effort that we had in our place to look up the up to 12-year results was really impressive because I was surprised to see that up to 15 years out, 92% of the patients still had their elbow for rheumatoid without a revision. So that was a 10-year follow-up. Joaquim Sanchez-Sotelo just looked up a couple of years ago, almost 500 patients followed for 25 years. And this is also very interesting because 90% of those patients had not had a revision. And so you can see the infection rate was not as high as you might think. And overall, this group did very well. Unfortunately, we don't see the rheumatoid very often, but it does emphasize that if you've got an inflammatory process, I am much more willing to do a total elbow on the young person because I know these data. At least this is the data at our institution. Finally, we looked up what is the outcome of all comers under 40 years of age, really young. And we had 55 patients, and inflammatory outnumbered the trauma by 2 to 1. But notice there were still about 20 trauma patients, and their surveillance was 8 years or 7.5 years. I should mention in this period, we did 133 interpositions. So what that means is that we were doing total elbow in a very, very young patient, but we had the ability to do interposition, but they weren't good candidates for the reasons Mark mentioned. And so here's the outcome. At 8 years, 91% were satisfactory under the age of 40. The inflammatory process were satisfactory 97% of the time, trauma 84%. Again, it emphasizes that the inflammatory patient that is very young that gets the implant has other joints and doesn't abuse it. But it's very tricky. This is a juvenile rheumatoid in the upper panel. And notice how that patient has virtually no canal on AP and lateral. So you got to pay a lot of attention to the young juvenile rheumatoid because they typically have almost no canal in the ulna and have very often a very narrow AP dimension on the humerus and a bowing of the distal humerus. In this instance, the post-trauma, usually the important thing is if you're going to have to use a longer ulnar component for some reason, be aware of the rule of 8s. 8 centimeters distal to the axis is where the bow of the ulna is. And so if you're using a long ulnar component, you may have to bend it to negotiate that curve. So that can be summarized by understanding the selection that we talked about, some of the diagnostic features, some of the features of the technique that we think are important today, and outcome. And those things all need to be known when you are making your decision on what option to use, particularly, once again, in the young patient. So Sorry about the delay and the technical problems we have, but we'll be happy to try to answer any questions.
Thank you very much, Professor. It was a wonderful presentation from you and Mark, dear friends. I will open for the audience to ask some questions for you, okay?
Sure, sure.
First of all, I have a question from Carlos Queiroz. He asking you about your protocol of rehabilitation after arthroscopy. Do you use CPM machine with or without anesthesia?
It's a great question, and we just finished a randomized control trial on that. So if patients have less than an 80-degree arc of motion before arthroscopy, they will benefit from CPM. And that's a statistical difference. They'll gain about 8 degrees more, 10 degrees almost at a year over patients. But importantly, they get back to work faster, they have less pain, and they are, or if they're retired, they get back to whatever activity they were doing faster. So they, on average, when we use a CPM for those contracted patients, is just kind of think of about 90 degrees. If they've got a 90-degree arc or less, they'll benefit from CPM. Now, not everybody has CPM, so that's the point. So, you know, if you have it available, I think it does help decrease the time to improvement. But if you don't have it, well, you're stuck, and they'll still benefit, but it just won't be quite as much. And we use a pain block, but we still do it as an outpatient. So when we when we do the cases, it's an outpatient procedure. They get their nerve block after a nerve check in the recovery room, and then they go home with that nerve block. It's with a pump, and then the nerve block comes out at 2 days, and then they continue on with the CPM machine up to about 2 weeks, because our basic science research suggests that the cells that are causing contracture are most highly active in the first 2 weeks, and then they start to die. So that's why we've set that kind of time point. And then after that, we see how long they can handle themselves out of a brace or out of the CPM machine. If they still need it, they can gain a benefit out to about 3 months. After that, it becomes very difficult to continue to stretch. So that's our typical post-operative rehab protocol. If I did not have a CPM machine available, I would definitely use a brace.
Okay, thank you. Mark, could you please close your screen, your presentation screen?
Oh, sure.
Okay, nice. I have a question for you, Professor Bernard. What about the case with infection? I mean, what is your protocol? You have a protocol for this, or is an individual process?
Well, we have some guidelines and principles. We kind of do thematic research here, clinical research, meaning that we get on a topic and then we look at it from several perspectives. And a few years ago, our focus was the infected elbow. And are you talking about an infected total elbow? Is that or is that the patient we're talking about, an infected total elbow?
Uh-huh.
Yes. Okay. So what we learned was that the two-stage reimplantation is still very viable, but of course it's pretty labor intensive. What we were looking at is the patient that was diagnosed in one of the studies, was diagnosed early after the operation, or was the symptoms of infection were relatively brief, say 2 or 3 weeks at most, and the implant was well fixed. We have a series where we did a one-stage debridement for cure and reattached the stems and left the stems intact. And the outcome of those were free of infection about 88% of the time, which is almost the exact same outcome we had with the two-stage implantation. So for the acute infection, particularly if it's not a particularly virulent organism, we do try a trial of debridement that might be staged. I used to just debride and put an antibiotic spacer and an antibiotic pin in, and then went back, took the antibiotics out, and reconnected the implant. And I think that's still a desirable approach if you can use it.
Okay, thank you. I
Yes.
think I know Lucas Jacques has some questions for you. Lucas, are you there?
Yes, Luizinho, I have several questions actually.
I know this.
Yeah.
We
So-
do too.
Yeah, let's start with Mark and the arthroscopy, okay? Well, you told us that the primary OA is a marginal disease, okay, Mark? And there is a discussion about the necessity of doing a capsulectomy or a capsulotomy or doing nothing, like Bud Savoy, he's just doing nothing with the capsule and the patient seems to be okay. Scott Steinman don't release the capsule in front of the radial nerve. So what's your thought about that? The necessity of doing a capsulectomy in a primary OA?
For primary OA, I do not think a capsulectomy or a capsulotomy is necessary.
Okay.
After you do the bony work, it's safer to not release the capsule. And those patients tend to get their motion without that release. And that's something that that we've learned over time is really, really helpful. And it's really important to know that because it's safer. Once you start releasing the capsule in the anterior part, as I showed, you know, those nerves are at risk. So you have a 0% nerve injury rate if you're not wading out into the capsule. So that's for primary OA, I think that's the safest thing to do.
I had a comment. It's important to understand that primary osteoarthritis presents with a spectrum. And I have seen some patients that presented with high-grade loss of motion by the time I saw them. And I can remember one that had tremendous amount of osteophytes. It was a very aggressive process of reaction to the degenerative pain. And that patient went from about 60 to 100 degrees. So obviously part of his problem was stiffness. So at that end of the spectrum, of course, it changes. And that's why it's so important to ask the person, what do you need the most? Get rid of your impingement pain, or are you looking to gain motion? And then on the table, when you take off the osteophytes, you can measure how much improved they are. And if that's what you had agreed that they would have, then you stop. But if that guy said, or lady, but it's usually a guy, if that said, I really need to get my arm out almost straight for whatever, and you didn't do it with your osteophytes, then that would be a time. So understand what your patient wants, and you can tell on the table what you've got, and then decide.
And that's also true if they need flexion. So I said that I do an open nerve release, because if you don't do that and then you bend them, they'll have a traction injury to the nerve. So as long as you're there, you've moved the nerve, now you've got the posterior bundle staring right at you. You can release that easily. So
Mark, do you do your ulnar nerve release in all cases?
No.
Okay.
I do an ulnar nerve release if they're symptomatic beforehand with my examination, or if they lack flexion. So if the main thing is gaining flexion and say they only flex to about 100 degrees, then I'll do the release.
Because I believe Dr. Driscoll does.
Yes, he does it in every patient.
Every patient, yes.
Yeah, I also do it if they have a Tinel's.
Yeah, so if they're symptomatic.
Sometimes they won't admit any symptoms, but in your exam, flex them up and see if they have a Tinel. And if that bothers them, particularly if you get more motion and flexion, they're going to be bothered more. And Samuel Antunes showed that they did not do as well if they had even subtle ulnar nerve symptoms. And so I know you don't have to release all the ulnar nerves, but if you don't know which ones to release and which ones not, I guess you can release them all.
I had a question from Mauricio Rafaeli, a great friend of us from São Paulo. For you, Mark, he asking you how long of the dynamic sternofixation in the interposition does it maintain? And how long they start the movement?
So with the dynamic external fixator, if I use that, and if I'm reconstructing both ligaments, they all get that. If it's just one ligament and it's just an augmentation, some patients don't require it.
Your sound is not good, Mark. Your sound is not good.
Okay, sorry. Can you hear me now?
Yes, yes.
Okay.
Okay.
So not all patients will require the fixator. So if it's just if the elbow is stable at the end of the case through a whole range of motion and you only did something to the lateral collateral, you got a good repair and your augmentation is good, then I don't think you need it. But if you're doing something on the medial side or the stability was an issue before surgery and you're reconstructing the ligaments, then I use an external fixer and it comes off between 4 and 6 weeks after the surgery. And it's a dynamic fixator, so they are moving the elbow through even a small range of motion while the fixator is on. So their motion is started immediately, and then it comes off. And that's taking the external fixator is another chance that you have to examine the elbow, and another chance that you have to actually get a little bit of motion at that period of time. So the external fixator is nice from that standpoint because it's a free examination, it's a free sort of objective manipulation.
Okay. I have a question from a friend of you guys, is Carlos from Curitiba, our friend.
Yeah.
Yes, he is talking about post-traumatic instability, severe coronoid insufficiency. Which is your graft option? Allograft, rib, iliac, or another better option?
If I'm for reconstruction of the anterior medial coronoid,
yeah,
I use an ulna. I use a regular coronoid because it fits really, really well, and that it requires a lot less shaping. So for me, that's my go-to if I have to reconstruct a coronoid.
Okay.
I
have a question. I have a question from another friend of you, Fabio Damolin. He asking you what is the follow-up of male with osteochondroplasty in osteoarthritis in young?
Typically, I'll see those patients back for just a wound check. Take the sutures out. That's usually about 10 days. And then again at 3 months.
Okay. Bernie, I have a question for you. Fábio, seu áudio está desligado.
Hi, Mark. Hi, Dr. Morrey.
Hey,
hello.
Hi. Nice to see you.
Good to see you.
And for how long do you think the improvement of the range of motion persist?
Great question. We were just talking about this yesterday, but typically if you take out the osteophytes and primary osteoarthritis, it's about 8 years before they'll start to recur.
But there's a disconnect between the X-ray appearance and what the patient feels.
Oh yeah.
Because virtually, if you follow a primary osteoarthritis, and let's say you do the procedure when they're, if you follow them long enough, the X-ray will always show some recurrence because they have a genetic makeup that makes osteophytes. That's what they do, and you haven't changed that. But they may not be symptomatic. So if you follow them by X-ray, this is some data from Japan, from Sapporo. If you follow them by X-ray, you'll start seeing the X-ray changes at 5 years, 6, 7, 8 years. But they may still have their arc of motion that you gave them. You know, it's usually 20 degrees or so just by removing the osteophytes. And they won't necessarily have impingement pain. But if they do, the nice thing about what you did originally is you can redo that arthroscopic debridement if you need to. But not a high percentage of patients go to a second debridement procedure. I don't know what Mayo's data are today, but when I was doing more of these, I think I only redid 2 or 3 of them. Not very many at all.
Good. Thank you.
For redos, it's not a high percentage.
Your sound is not good, Mark.
It's in the single digits or in the teens, the low teens in terms of patients that had, were 8 years and then required another surgery. So even though you see it on X-ray, they won't be symptomatic, as my dad said. And so they oftentimes don't need that. But you start to see it, really around 5 years, you'll see them on X-ray.
Okay. Bernie, during this Teach of the Teacher course in this year, Odrisco presented the diamond approach technique. Do you think it's not too hard, too aggressive for the triceps, this technique?
I wasn't at the course, so I don't know exactly what he said, but I'll let Mark comment on it.
So in terms of repair, we went to the lab and we did a lot of dissections for this technique. The problem that I have with the technique, and the reason that I don't use this technique primarily, is if the patient gets an infection, and I just treated one of these yesterday, if the patient gets an infection, then the triceps goes away 100% of the time. But if you had a paraolecranon where you left the triceps intact, the patient will maintain their triceps. So I think it's not a high percentage where those, where you're getting an infection, but if it's, 3 out of 100, that's still a risk that I'm not willing to take, because I have good enough exposure with the other technique. And so for me, and this is just me, the strength of that repair is great if there's no infection, if you can avoid that. But if there is, then you've got a real problem.
Okay. Let me just make a couple of comments too. The reason that the Brian Morrey approach was developed was because of our concern of the various tongue of triceps procedures. If it got infected, that tongue went away. And Dick Bryan was the one that one of the main reasons to develop the Brian Morrey approach of the peel off the triceps and keep it in continuity was to avoid the big healing process of that VY type of incision. And interestingly enough, we studied in the laboratory patients that had the Brian Morrey and those that had a variation of that kind of an approach. And the Brian Morrey was statistically stronger in extension than that. So in our early years, the reason for the Brian Morrey was to abandon that because we were concerned, like Mark said, about infection, and because they were actually weaker in the lab.
Luis, may I add a question regarding?
Please, go ahead, Lucas.
Okay. The paraolecranon triceps approach is very elegant, but I have some difficulty to access the ulna with the rigid reamers that the current Morrey prosthesis has, the old one. Would it be wiser to make a small incision in the central triceps to get a direct access to the ulna, or you just can do it with the rigid reamers as well?
Well, no, it is hard. I mean, it is more difficult. I prefer to dislocate my elbow toward the medial side because it relaxes the ulnar nerve, and then I can use the radius as a judge for rotation, but also because you have better access. So I think taking it to the medial side is a little bit easier for your shot, for the straight shot. But I will also do what you said, which is make a counter incision sometimes to put a pin in. So you have a better shot, but also removing enough of the tip of the olecranon so that you can move it out of the way. So there's a bunch of different, I guess, subtleties to that, which gives you a better shot. And then the use of the retractor. So if you use a Holman retractor, say on the medial part of the cornoid, that typically will move the triceps out of the way enough to get a straighter shot down the canal. But if you're more radial on the ulna, the straighter the shot that you have down the canal. So that typically is a little bit easier, but it's not a mistake to make counter incision and prepare through there. I've done that in juvenile rheumatoid arthritis, where my dad was talking about, where they've got a great big bow. That's a great technique. And we actually wrote that up a couple of years ago of working through exactly what you just said.
The other thing is if you saw that dissection that we had in our talk, you notice how easy you could see the ulna, and there you would be easy. What is really interesting is every time you go to the lab and do a cadaver, that ulna just flops over. And you say, wow, that's pretty good exposure. It doesn't in that way when you have arthritis. You have to work at it. But the important point is, what I learned is I didn't do an aggressive enough release of the soft tissue when I was first starting it, and I struggled. Now I really release the soft tissue because they heal very well, and there's no consequences that I can tell. So right off the bat, when I'm doing the initial exposure, I look to see if I'm going to be able to get to my ulna easily. And I just keep releasing soft tissue because I know in the normal anatomy, it just flops over there. So that means it is possible. But going central, doing a linear split of the triceps if necessary is always an option. But notch the take the tip off the olecranon and then notch it in line with the canal. And that will add some ease to getting your preparation.
Yeah, the part about the soft tissue releases is so important. Like that's an experience that all of us have had, where it's hard to couple the implant, or it's hard to get exposure to the ulna, and it's because these patients are post-traumatic. They've got lots of scarring, or their arthritis in general causes the contracture. So the soft tissue release is going to make you much faster, much more efficient. Take that soft tissue off of the humerus, it heals really well, and you'll be much happier with your exposure.
It's easier to re-articulate it because if you're struggling to prepare the ulna, you're going to struggle to re-articulate because, so recognize that and do as much as you can right off the button. It'll save you time.
Hold this humerus.
Nice.
Thank you.
Okay, I think we are on time. I know we have much more questions, but because the time, we need to move on to the second part of the meeting.
Okay. Sorry for the late start.
Bernie and Mark, it was an amazing meeting. You are great. As I told you yesterday, Mark, I like you very much, but I love Bernie.
me too.
Well, it's always good to see our friends.
Yeah.
And we're very proud. We're very proud when we ask you what the level of competency was with scoping and interposition. We're very proud of what you've been able to do with the education that you have and with your experience. It's very impressive. Thank
you very much, Professor. Thank you very much. Fabio, João, do you want to say some words, please?
On behalf of our society here in the northeast of Brazil and north of Brazil, thank you very much. We really appreciate you guys joining us in this Saturday. Please be safe, be healthy, and we can see each other in the next meeting.
Yes.
You too. Thank you so much.
Thank you.
And have a good rest of your meeting. Bye-bye.
Thank you very much. God bless you.
Thank you. Thank you. Bye.
Isso aí, pessoal. É uma pena que a gente teve que interromper aí. Eu sei que tinha muitas perguntas. Lucas, me desculpe, eu sei que você tinha várias perguntas. Eu também tinha mais, mas problemas técnicos no início atrapalharam o início da coisa. E as aulas deles foram bem extensas, foram assim, completas. Eu acho que facilitou muito a vida aí da mesa redonda. E então vamos começar aí com a mesa redonda com o Lucas Jacques, nosso amigo muito querido lá de Minas, de Belo Horizonte, é quem vai moderar essa mesa, um expert em cotovelo, um dos maiores conhecedores de cotovelo do Brasil, sem dúvida. E junto com ele, debatendo, estará o Marcílio Oliveira, amigo querido também lá de Natal, e o Tiago Serpa, outro amigo querido lá de Recife. O Renato, de Fortaleza, por motivos pessoais, não pôde estar presente agora. Eu tomei a liberdade, sem consultar o Fábio e o João, me perdoem, de convidar o Fábio Dalmolin para fazer parte do terceiro elemento da mesa. Então, por
Provadíssimo.
Favor, podemos conversar. Lucas, fica à vontade.
Luizinho, obrigado pelo convite. Para mim é uma honra participar desse webinário, sobretudo depois dos Morrey, né? Eu vou fazer uma analogia aqui, eu acho que vocês vão concordar. Para mim, o professor Morrey, ele está para a cirurgia do cotovelo, assim como o Charles Neer está para a cirurgia do ombro.
Sem dúvida. Sem dúvida.
É o pai da cirurgia do cotovelo moderna, sem sombra de dúvida. Bom, eu não vou me delongar muito, porque o almoço já está aí. E a ideia desse... vocês estão vendo minha tela, não?
Não, tem que compartilhar ainda, Lucas.
Agora não?
Sim.
Agora estamos.
Ok. A ideia aqui não é colocar ninguém em problema, é simplesmente escutar a experiência de vocês com o que eles acabaram de discutir, né? Então, trouxe alguns casinhos e vamos tentar ser breve nessa discussão. No primeiro caso, um paciente de 45 anos, trabalhador braçal, tem um passado de uma cirurgia de epicondilite lateral e a dor leve no cotovelo, associados aos episódios intermitentes de dor aguda, bloqueio ósseo e limitação progressiva da ADM. A dor, sobretudo, nos extremos do movimento. Então, acho que esse é um paciente bem típico, certo, Thiago e Marcílio e Fábio?
Sim.
Né? O diagnóstico, eu acho que é mais do que evidente, né? Essa perda de flexo e extensão, e o raio-x demonstra a patologia em questão. Algum comentário de vocês até aqui? Não?
O mais importante é que você falou do movimento, que ele tem dor só nos extremos do movimento, né? Que é exatamente decorrente dessa artrose primária que ele tem, desse desgaste marginal, formação de osteófitos, né?
Exato, Marcílio. Essa era uma pergunta que eu queria fazer para eles, mas acabou de não tendo, vou fazer para vocês. Num quadro inicial da artrose primária do cotovelo, vocês têm alguma experiência com tratamento não cirúrgico? Por exemplo, ácido hialurônico, alguma coisa desse tipo, infiltrações repetidas? Qual a experiência de vocês?
Não, minha experiência é mais com a fisioterapia. O ácido hialurônico, eu realmente não tenho experiência em cotovelo. E tem trabalhos realmente que mostram que a longo prazo não faz diferença, né, nesse tipo de paciente. Então, a termo não cirúrgico, nós teríamos a fisioterapia, teríamos os splits, né, as imobilizações, para tentar manter a extensão do paciente, extensão e flexão, dependendo do déficit do paciente, e o controle álgico, né?
Ô, Lucas,
Lucas, oi.
Pode falar, Fábio.
Não, pode falar, vamos lá, depois eu falo.
Eu tenho 2 pacientes que jogam vôlei e já tem uma artrose primária e que tem um pouco de limitação, e eu acabei fazendo 2 ou 3 infiltrações exatamente naqueles momentos do campeonato. Eles evoluíram bem, participaram do campeonato, mas assim, é profilático, né? Não vai resolver.
O Marcelo, a infiltração foi com o que, Marcelo?
Eu fiz com corticoide e estilo.
Corticoide e estilo, certo.
Lucas, eu acredito que esses osteofitos ali, eles doem. O Odrisco falava muito em broken osteophyte, né? Que tu tem um osteófito. Então, o mecanismo de flexo-extensão ali, quando mexe nesses osteofitos, eles doem. Então, eu acho que esse é o grande momento de fazer uma ressecção artroscópica, onde eles vão ter muito benefício e vão progredir menos e mais lentamente. Então, eu não acredito muito em tratamento conservador nesses casos em que a gente vê uma barreira mecânica. Até por isso que eu perguntei para o Morrey quanto tempo demorava a evolução deles. Tu vê que é longo, né? 10 anos eles falam assim de melhoras com as remoções dos osteofitos, né? E obviamente quanto menos, melhor.
Eles falaram de recidiva.
De recidiva, né?
Depois de 8 anos o processo começa de novo a acontecer.
Então, eu acho que quanto mais cedo, mais lento vai ser, né? O retorno.
Eu acho que quanto mais rígido, o que eu percebo, mais lento esse movimento vai ganhando com o passar dos meses. Não é uma coisa tão imediata como se poderia esperar. Mas olha, nesse preparo então para um tratamento cirúrgico, vocês pediriam algum outro exame adicional ou o raio-x está bem satisfatório para vocês?
Eu acho que a tomografia ajuda bastante para a gente observar principalmente isso, essa imagem que a tomografia nos ajuda, né? Se é só esse bloqueio de extensão é só de um osteofito da ponta do olecno ou se realmente tem corpo livre nessa fossa, tanto anterior quanto posterior. Como foi mostrado na aula, para ter o planejamento cirúrgico do que você vai precisar abordar e retirar.
Muito bem.
Eu concordo com o Thiago. Eu acho que a tomografia E a tomografia 3D, a simples e a 3D, ela é quase um exame coadjuvante do cotovelo. Acho que talvez seja uma das articulações que mais peça a complementação com a tomografia 3D. E acredito que logo, com o acesso, vão ser os printing, as impressoras 3D mais fáceis. Acredito que a gente vai pedir como se fosse uma imagem logo, porque facilita muito, né?
E alguns de vocês têm experiência com tratamento cirúrgico aberto para esse tipo de patologia? Tipo alter bridge cachewage, tipo a cirurgia de coluna.
Coluna lateral, né? Alter bridge não tenho experiência com alter bridge, não.
Eu já fiz algumas, mas elas são cirurgias, eu acho que essa é uma cirurgia artroscópica. Eu não tenho os mesmos resultados que eu tive com a liberação aberta, com as columns procedure. A dor pós-operatória acaba deixando ele mais duro. Então, eu acho que essa é uma cirurgia que é artroscópica. Acho que o resultado artroscópico é muito melhor, mais rápido. O paciente sente menos dor e ele perde menos ADM no pós-operatório.
Quando você faz a liberação aberta, a gente consegue liberar bem partes moles, liberar um pouquinho também a fossa do olecano posterior, mas o acesso da gente anterior ele é muito minimizado na cirurgia aberta em relação à cirurgia artroscópica.
Isso.
Bom, essas são perguntas que eu acabei fazendo um pouco para eles, mas eu queria saber o que vocês andam fazendo, então, sobre a neurorise do nervo ulnar, quando vocês as fazem, e na questão da cápsula, como eu comentei com o Morrey, se vocês fazem de rotina na artrose primária ou não?
Se o paciente tem queixa, né, do medial, um tíneo positivo, eu acho que vale a pena a gente já fazer a neurólise, né? E principalmente se ele tem um bloqueio importante de flexão, alcançando o grau de 90 a 100 graus também, acho que ele vai sofrer quando você recuperar a amplitude de movimento. Então vale a pena realmente fazer a liberação.
Fábio e Marcílio?
Eu acredito que a neurólise é exatamente isso, Lucas. Se o paciente já tiver sintomatologia de nervo, ou então a limitação de movimento de flexão. Acho que nesses dois casos estaria indicado a gente fazer a neurólise.
Lucas, eu tenho como rotina, assim, eu sempre inicio a artroscopia e abro uma incisão de 2 a 3 centímetros sobre o ulnar, porque eu não me sinto confortável de mexer na goteira ulnar ali, na limpeza artroscópica, na sinovectomia ou na ressecção dos osteófitos, sem estar com o ulnar na minha mão. Então, eu sempre faço uma neurólise, individualizo o ulnar, seguro ele ali com um penrosezinho para não ter risco de pegar no shaver, e então automaticamente eu faço sempre a neurólise dele.
Eu também faço de rotina, Fábio, não só por essa razão, mas também por já ter experimentado isso. O Rodrigo fala muito isso em relação a alguns pacientes que têm mesmo uma perda pequena de flexão, mas que quando você ganha essa flexão, eles começam a desenvolver um sintoma no nervo ulnar pós-artroscopia e se acaba tendo que liberar porque ele não ganha movimento. E, sobretudo, para você acessar a cápsula póstero-medial também com mais segurança, né? É bem mais simples você deslocar o nervo e acessar diretamente essa cápsula. Mas falando de cápsula, e a capsulectomia? Vocês fazem de rotina a capsulectomia anterior?
Isso, acho que no final do procedimento, se você não alcançou o ganho de extensão completa, acho que é a indicação de fazer, né? Muitas vezes você abordando os osteófitos e o recesso posterior, você já pode conseguir a extensão completa. No final, você avalia se essa capsulectomia vai ser realizada ou não.
Eu concordo com o Thiago. Poucas vezes eu não fiz, porque tem vezes que a cápsula é redundante e quem segura são os osteófitos. Mas, no geral, eu acabo fazendo, mas algumas vezes não precisa mesmo. Acredito que sim.
Capsulotomia e não capsulectomia, Lucas.
Ok. O Dr. Paulo Sérgio, de Curitiba, prazer, Dr. Paulo, tê-lo conosco, ele fez uma colocação interessante na cirurgia aberta, o procedimento da coluna, que é uma abordagem lateral. Não seria muitas vezes importante você fazer um acesso medial acessório, imagino eu, ou um acesso medial direto ao invés da coluna lateral? Algum comentário de você sobre isso?
O que pode ser associado ao procedimento da coluna lateral é fazer um acesso posterior direto, né? Para você ter uma melhor visualização e controle de uma osteotomia, ressecção da ponta do olecne e do recesso posterior.
Se tiver receio do nervo ulnar, né, principalmente nas limitações, aí sim eu associaria uma incisão medial. Mas com incisão lateral a gente consegue fazer toda essa remoção.
É isso, Paulo. Eu também, eu acho que a gente consegue visualizar bem só. O único medo é o nervo ulnar lá do outro lado, que seria o receio, mas normalmente a ressecção por lateral consegue abordar toda a cápsula e ressecar toda ela.
Eu também, doutor Paulo. Pode falar, Thiago, desculpa.
Sim, um enquete aí com vocês. Já quando vão fazer, o paciente tem queixa de ulnar, né, e tem uma rigidez maior do cotovelo, e vão fazer a neurólise do nervo ulnar. Se vocês já fazem, quando fazem essa abertura, né, a neurólise já fazem a ressecção desse osteofito medial e liberação da banda posterior do colateral medial já aberto mesmo. Pode aproveitar esse procedimento, já fazer isso, depois você parte para a parte lateral e o restante por via artroscópica.
Deixa eu responder primeiro o doutor Paulo. Doutor Paulo, sim, quando o nervo ulnar é a questão e você tem que abordá-lo, eu prefiro fazer qualquer cirurgia de liberação por via medial. Eu uso acesso de Hodgkins para isso, para acessar anteriormente e posteriormente eu mantenho o nervo ulnar na posição dele, só faço uma liberação, uma neurolise, para acessar a parte posterior. Mas tudo por via medial e não por via lateral. Quando eu tenho certeza e convicção de que eu não vou mexer no nervo ulnar, eu vou para lateral. Só lateral. Tiago, sim, quando a gente faz esse mini acesso ao nervo ulnar, e você faz uma neurolise como se fosse um túnel do carpo, né? Proximal e distal, a gente aproveita, afasta o nervo, faz uma ressecção da cápsula póstero-medial e, eventualmente, qualquer osteófito ali se acaba já abordando. Mas eu tenho feito assim, Fábio.
Sim, eu também. Acho que esse é o caminho também. Da mesma maneira.
Ok, vamos avançar. Eu vou... A reabilitação, teve muita pergunta sobre reabilitação para o pessoal, os Morreys, e o Mark falou alguma coisinha, mas em particular nesse paciente que vocês fizeram artroscopia, vocês têm algum cuidado nessa reabilitação? O CPM é importante para vocês? É uma realidade para vocês? A fisioterapia é uma realidade para vocês nesse pós-operatório?
Aqui não tenho experiência com CPM. Eu acho que vale a pena o uso das órteses, né? Para opor o movimento, se você está com um déficit de extensão, você pode imobilizar o cotovelo mais em extensão. E a fisioterapia cuidadosa sem forçar, né? Sem aquele movimento mais alto passivo, para não retornar esse grau de rigidez do cotovelo. Acho que é muito importante essa reabilitação, que às vezes muito vigorosa, com muita força, pode prejudicar a recuperação do paciente.
Eu também não disponho de CPM e eu acabo deixando o paciente 3 a 5 dias internado para fazer essa fisioterapia no hospital com analgesia, para a gente ter certeza que está tendo um início de fisioterapia melhor.
Lucas, eu tenho uma teoria assim, que eu juntei com aquilo que a gente via lá na Mail e juntei com aquilo que é realidade nossa, né? Eu lembro que o Driscoll falava que o CPM funcionava porque a mobilidade precoce fazia desinchar. E o que eu fiz quando eu comecei a usar um Robert Jones de algodão e muita atadura para comprimir. E deixo eles com um splint que eles faziam lá na Meio em extensão durante 48 horas, de 36 a 48 horas, e com o braço no ar. Eu percebi que é impressionante. Os pacientes que não edemaciaram o cotovelo, eles têm um ganho de ADM fácil. O problema do cotovelo é o edema. Se ele tiver edema, ele fica como um balão. Ele não tem para onde fletir, porque ele não deixa. Então, isso dá uma cadeia de dor e limitação de mobilidade. Então, eu acho que o grande segredo do cotovelo não é o CPM. Eu acho que é o não edemaciar E daí a mobilidade depois também, que não precisa ser tão precoce assim, 48 horas, 72 horas, e fazer mobilidade. Mas o grande segredo é não edemaciar. Não acredito que o CPM seja a chave. A gente não tem CPM e se consegue uns resultados muito bons.
O Fábio, concordo em gênero e grau. Acho que essa questão do CPM é muito batida na meio, mas conhecendo e visitando muitos outros centros ao redor dos Estados Unidos e do mundo, eu nunca vi ninguém usar CPM. Os resultados continuam sendo sempre muito favoráveis, sobretudo na osteoartrose primária, né? Você pode contestar a CPM talvez numa rigidez mais agressiva do cotovelo, uma liberação de cotovelo pós-rigidez, mas na artrose primária, sem sombra de dúvida. Eu não acho nem que a fisioterapia é necessária, nem que a CPM seja necessária. Bom, acho que esse assunto a gente se encerrou. Eu não vou entrar em detalhes aqui de técnica, porque já foi muito bem explanado pela família Morrey. Vamos para o segundo caso, então. Esse é um caso que sucede um pouco mais de discussão. É uma paciente de 49 anos. Ela tem artrite reumatoide, desde mais nova. Não é artrite reumatoide juvenil, mas já é uma doença instalada há pelo menos 10 anos. Dor no cotovelo direito, sem resposta às drogas modificadoras da doença. E há 5 meses ela foi submetida a uma sinovectomia aberta e a ressecção da cabeça do rádio. Ela, a partir daí, desenvolveu uma piora progressiva da dor e da função desse cotovelo dela, quando ela chegou até a mim, e essa é a radiografia da ocasião. Aqui é simplesmente discutir conduta, pessoal. Qual que seria o próximo passo para essa moça?
Lucas, ela tem uma artrose inflamatória aí, já foi feito um procedimento inicial. É uma paciente jovem, né? 45 anos, 49?
49.
E eu ficaria com medo de fazer uma prótese total nela. Eu acho que uma opção é fazer uma artroplastia de interposição, acho que seria uma boa saída para ela.
Esses pacientes com artrite reumatoide realmente eles são comprometidos numa faixa etária mais jovem, né? E já foi feito 2 procedimentos dela, já foi feito uma artroplastia de ressecção da cabeça do rádio. Você vê que a impressão nesse raio-x já está começando com um valgo aqui, provavelmente pela insuficiência já da cabeça do rádio. E geralmente esses pacientes eles evoluem com instabilidade, esses pacientes com artrite reumatoide, né? Porque a doença ela não é só óssea, ela tem um pânus, né? Tem um processo inflamatório que vai causando instabilidade ligamentar, às vezes grosseira, né? Então, é um caso complicado nesse paciente. Mas sabe que nesses pacientes com artrite reumatoide, muitas vezes eles evoluem para artroplastia total em idades mais precoces.
É um caso complicado, né? Ver que o numeral dela já está bem ruim, né? Eu também tenho medo de fazer prótese por nossas situações de revisão aqui. O Morrey mesmo falou, né, que quando tu pensa em prótese, tem que pensar na revisão. Então, eu tentaria fazer uma artroplastia de interposição.
Eu trouxe esse caso exatamente para entrar nessa discussão de artroplastia de interposição e de prótese total primária, né? Luizinha, sua experiência com artroplastia de interposição nesses pacientes, você está aí ainda?
Estou sim. Deixa eu mostrar a minha beleza aqui para vocês. Espera aí. Então, eu particularmente, por conta da idade, e a gente sabe que esse ossinho reumático é bem ruim, até mesmo para sustentação de prótese e do cimento ortopédico, por mais pleno que ele seja, com menos calor, próprio para prótese, eu ficaria mais em fazer artroplastia de interposição. A gente, como você sabe, Lucas, a gente tem feito artroplastia de interposição com enxerto dérmico. Nós já temos 16 anos fazendo isso, temos uma casuística bem legal, fonte de origem do nosso doutorado. E eu, sem sombra de dúvida, eu pensaria em fazer uma artroplastia de interposição. Na minha mão, o enxerto dérmico funciona muito bem. Uma coisa interessante que na aula que eles falaram foi exatamente isso, né? Eles têm uma boa experiência com artroplastia de interposição, mas tem um porém. os melhores resultados deles passaram a ser a partir do momento que eles começaram a usar o tendão de Aquiles.
Exato. O Thiago levantou alguns pontos interessantes nessa discussão. A ausência da cabeça do rádio no paciente com artrite reumatoide e já uma descompensação desse cotovelo, né? Uma ligeira queda em valgo desse cotovelo. E a gente sabe que os resultados da artropatia interposição com algum grau de instabilidade começam a se deteriorar bastante, né? E aí?
Essa é uma observação bastante pertinente. A maior complicação da artroplastia de interposição é exatamente essa, a instabilidade. Então, ela não pode ser simplesmente a artroplastia por si só. Ela tem que ser, no ato cirúrgico, você tem que ver como é que se encontra a estabilidade dessa articulação. E, obviamente, se ali você percebe que não está tão seguro, eu faço a reconstrução ligamentar e coloco o fixador externo dinâmico, com distração. Faço uma distraçãozinha de uns 3 milímetros. Isso facilita, no meu modo de entender, a integração osteoenxerto.
Eu acho que um ponto interessante na etiologia é que com as drogas modificadoras da doença, o número de artroplastia, de procedimentos, né, em cotovelo de paciente reumatoide diminuiu bastante. Né? O que a gente tem que considerar é o seguinte: esse é um paciente que o tratamento medicamentoso falhou. Né? Então, é um ponto importante para ser levado em consideração. Aí, realmente, Lucas, é um caso bastante complexo, porque a gente sabe que a doença está em atividade, não está melhorando, vamos fazer um procedimento de interposição, mas fica sempre aquela dúvida, o quanto vai durar, né? Já que a doença não está controlada.
E esse caso eu acho que é um que é imperativo fazer a reconstrução, né? Por isso que talvez acredito que nesse caso o Aquiles é de eleição, porque aí já aproveita o flap e faz a reconstrução medial.
Vocês têm acesso assim a banco de tecido fácil?
Não, esse é um grande problema.
Pois é. Esse é um problema. Então, na nossa realidade, às vezes, a artropatia interposição também é um procedimento difícil de ser feito, né? O Luizinho tem uma boa experiência com DER, mas como você pontuou bem, Fábio, reconstruir ligamento aqui é mais difícil com aquele enxerto, né? Isso talvez me levou, isso aqui é só para um alerta, o cuidado para não evitar-se ao máximo fazer uma ressecção da cabeça do rádio num paciente com artrite reumatoide e a queixa de sinovectomia. Esse é o cotovelo do outro lado, que também é sintomático, mas que não foi abordado. Eu, diferentemente de vocês, parti direto com a prótese total. Eu confio muito nessa literatura da Mayo de que na artrite reumatoide o paciente tem uma sobrevida muito boa com a prótese, ou seja, em 10 anos mais de 92%, apesar da idade desse paciente. E das dificuldades exatamente da questão de banco de tecido, de reconstruir, usar o Aquiles e o perfil da paciente também, né? Esse é o resultado logo imediato, e aqui o resultado com 5 anos, uma prótese ainda bem fixa, apesar de vocês notarem uma absorção do enxerto que eu coloquei, mas até então paciente satisfeita. Né? Não, está bem fina essa prótese, ela está bem. O outro cotovelo que incomoda mais agora. Mas é o que eu falei, eu acho que a gente não, era um caso exatamente borderline para a gente discutir prós e contras de cada um das técnicas, né?
Lucas, eu estou vendo uma âncora aí no olecrano. Qual foi o seu acesso aí para o tríceps?
Não, eu fiz o Brian Morrey e eu quis reforçar além dos pontos transósseos com uma âncora para dar uma segurança maior pela idade da paciente, mas hoje em dia a minha tendência é, como o Dr. Morrey apresentou, preservar o tríceps ao máximo nesses pacientes.
Interessante, Lucas. Sabe que é um dos raros casos que eu vi a reabsorção ali do enxerto. O que tu acha? Não te preocupa? Porque eu acho que esse enxerto é muito importante, é um grande diferencial. Mas aqui parece que tem, ó. Eu acho que
ele estava aí, o enxerto. Me preocupa dois cenários aí, no caso, né? Da longevidade da prótese, né? Porque que a gente perde não só o componente rotacional de estabilidade que a flange dá, mas também o de batente posterior, mas também algum tipo de processo inflamatório acontecendo ali, seja ele o processo reumático, que levou à absorção desse enxerto, ou até um processo infeccioso de baixa virulência. Apesar de já ter 5 anos e sem sinal de soltura e dor, são preocupações que me afligem também, Fábio.
É uma coisinha aí na parte distal aí do encaixe da prótese, você vê já daí com 5 anos um pouquinho também de radiolucência, né? Periférica, né?
Isso próximo ao coronoide ali.
Queria fazer uma pergunta para o Luizinho aí. Ô, Luiz, a tua experiência com enxerto dermal, está tirando de onde esse enxerto?
Então, esse é o enxerto que o Morrey ele publicou isso no livro dele. Eu tiro da região inguinal, na linha do biquíni. Então, a cicatriz fica totalmente até embaixo do biquíni, da sunga do indivíduo. Até do ponto de vista cosmético, é interessante. Foi uma iniciativa minha na época que eu era residente lá na USP. Na verdade, a tentativa, né, lá, mas os professores ficaram um pouco receosos com a ideia. Então, de lá eu fui para meio, e quando eu voltei da meio, já aqui em Salvador, eu comecei a aplicá-la. Então, eu tô assim, assim, a colocação do Lucas é bem pertinente, né? Mas assim, diante da nossa realidade, assim, o que a gente tem entre face a lata e a derme, eu prefiro muito mais a derme, por questão do sítio doador. A derme, a espessura dela, eu não preciso dobrá-la, a espessura dela para mim é bem suficiente. A resistência dela, apesar de que eu ainda não tenho um estudo com relação à resistência de força de tração, eu precisaria de um aparelho para isso, e eu não disponho, me parece muito bom. Eu tenho caso, inclusive, de colegas nossos médicos, que a gente chegou a fazer, e tem bons casos que não precisei mais mexer nesses cotovelos. Eu tenho um bom número nesse sentido.
Luizinho, eu já tentei, fiz uma, só que era um paciente com uso crônico de corticoide e a derme era muito, muito fina, ou quase inexistente. Tu tem essa experiência e nesses casos daí?
Então, exato. Aí com paciente, na verdade, o uso crônico de corticoide é melhor você fugir desse tipo de paciente, né? Porque os caras, as partes moles deles e até a própria nutrição óssea é muito ruim, né? E é isso mesmo, eu já tive uns 2 casos assim e o resultado acabou indo para a prótese.
Ô, Luizinho, deixa você à vontade. Tem um terceiro caso, mas o tempo é você quem controla.
Deixa eu só Lucas e o Fábio, vocês usam face a lata na interposição?
Sim.
Simples ou faz ela dupla, dobram ela?
Dupla.
Dobrada.
Dobrada, certo.
Algum dia vamos rezar que a gente tenha bancos de tecidos que
Fornecer Aquiles.
O Aquiles, você vai para um outro patamar, de fato, sabe?
Isso.
Luquinhas, fica à vontade. Eu acho que dá tempo, sim. Temos uma audiência com 54 colegas ainda, significa dizer que a mesa está muito interessante.
Esse é o meu último caso, então. É um colega nosso, de 27 anos, psiquiatra. Ele teve um acidente automobilístico muito sério, no qual ele luxou os 2 cotovelos e teve um TCE importante e um TRM alto. Foi feita a redução dos cotovelos na urgência, eles foram imobilizados em tala, foi feita a estabilização do TRM e seguido de uma UTI prolongada, né? Ele evoluiu com uma tetraparesia em maior grau nos membros inferiores e a função dele hoje, no caso, na ocasião, ele conseguia deambular com o andador e o auxílio de uma pessoa para dar uma ajuda também. Estava começando a andar com o andador. A grande questão é que ele tinha uma rigidez bilateral nos cotovelos. Ele tinha o cotovelo bilateral rígido a 60 graus, nos 2 lados. Ou seja, ele era muito bom para usar o andador, mas ele não fazia higiene pessoal, ele tinha muitas outras dificuldades. Então, a queixa principal dele era essa, a rigidez. Quando a gente via a radiografia, essa era o raio-x do cotovelo que foi abordado, né? Esse é o cotovelo esquerdo, se eu não me engano.
Anquilose, né? Anquilosou aí.
Essa é a questão.
TCE associado, né? Provavelmente
Desculpa.
deve ter. O TCE associado juntou com a luxação, pode ter evoluído para esse quadro aí, né? De anquilose.
Exatamente. O raio-x do outro lado é muito parecido, sabe, Thiago?
Ô, Lucas, a queixa dele maior é a limitação ou ele tinha dor associada?
Não, não tem dor. O cotovelo não mexe.
Não mexe nada.
Ele não tem dor nenhuma. O problema dele é que ele tem ambos cotovelos rígidos a 60 graus. O que ele me pediu? Ele falou, eu preciso de um cotovelo para eu fazer higiene, para eu escrever. O outro cotovelo está ok, assim, porque eu preciso dele estável e forte para eu usar meu andador.
O Lucas, acho que nesse caso aí, realmente avaliar um cotovelo do paciente, é o braço dominante, né? E talvez esse seja um caso aí para você fazer o procedimento aberto, retirar essas ossificações, essa rigidez. Muitas vezes você se surpreende com o centro de uma articulação preservado ainda, quando retira isso. E talvez avaliar o caso que sim, para uma artroplastia de interposição, né? Escolher um membro aí para avaliar isso. Talvez esse seja um caso para isso. Olha aí, ó. Talvez mostre aí o interior da articulação preservada, né?
Isso, eu concordo com o Thiago, não é incomum a gente fazer a ressecção e ter a articulação preservada. Não tem outras imagens da toma ali?
Essa toma ele trouxe, ele é um paciente do interior e realmente eu tentei selecionar a melhor tomografia, sabe, Fábio?
Sim.
Mas o que eu quis mostrar com essa imagem, eu concordo com o que vocês pontuaram. Eu acho que ele tem uma articulação preservada no lado radial, ou seja, a radiocapitelar muito boa, mas quando a gente vai chegando para o lado ulnar, eu começo a não ver muita dissociação do húmero distal com a una proximal. Como se ali tivessem cruzado mesmo essa articulação, sabe?
Sim.
E não seja uma coisa só periférica, como é do lado radial.
Outro fator que tem que pensar também é que ele luxou o cotovelo, né? Então, pode ser
exato.
quando solte tudo isso aí, ele não tenha reparo ligamentar. Então, tem que pensar na estabilização pós.
Fica instável.
E aí, tu?
Casinho, hein? Manda pro Lucas.
Eu acho que uma das opções que teria é essa que o Thiago falou mesmo, é fazer um procedimento aberto e se a gente tiver essa opção de fazer uma artroplastia de interposição. Eu acho que não, a gente fica sem muita opção para o caso.
Muito bem.
E nesse caso, sim, pensar, entrar preparado para a reconstrução ligamentar e talvez avaliar, botar um fixador externo dinâmico aí, né? Porque ele vai ter que proteger, é o único cotovelo que a gente tem que garantir uma estabilidade nesse cotovelo no pós-operatório.
Muito bem. Eu acho que vocês estão bem demais, pessoal. E foi exatamente o que eu fiz, sabe? Entrei preparado para fazer só uma liberação, mas também entrei preparado na necessidade de uma eventual articulação não preservada, fazer exatamente a artroplastia de interposição. E foi exatamente o que eu fiz. Eu também fiz uma reconstrução ligamentar associada. E no pós-operatório, vamos ver isso aqui. Desculpa, no pós-operatório. Esse aqui era o vídeo, mas meu vídeo não vai correr, infelizmente. Eu usei o fixador externo por causa dessa reconstrução. Você vê os túneis ósseos da reconstrução nesse slide mais inferior à direita, para que eu protegesse essa reconstrução e ele começasse a mobilizar o cotovelo.
Usou o que para a reconstrução, Lucas? Palmar?
Associei a face lata com o palmar. Exatamente.
O Lucas reconstruiu qual lado? Medial, lateral?
Eu reconstruí o lado não dominante dele, sabe?
Não, assim, o ligamentar. Você fez bilateral, ligamentar ou só fez...
Não, eu reconstruí o lado lateral.
O lado lateral, certo.
Lado lateral. Eu não tenho follow-up final desse paciente. Médico, ele é um paciente difícil, né? Ele voltou para o interior dele, mas ele está muito satisfeito. Falei com ele por telefone há pouco tempo. Aliás, no início ele ficou muito insatisfeito com isso, sabia, pessoal?
Foi? Qual era a queixa dele?
Eu vou te explicar. Não. Tirou o fixador, o movimento dele estava muito bom. O problema é como ele tinha uma tetraparesia, e era impossível avaliar isso antes, o tríceps dele era muito fraco nesse lado, era um tríceps M2. Ou seja, toda vez que ele tentava estender o cotovelo contra a resistência, por exemplo, para usar o andador, o cotovelo fletia.
Ele não sabia que tinha isso, que estava enquilosado o
Exato.
cotovelo, né?
Exato. Então, ele apoiava para usar o andador, o cotovelo esquerdo fletia.
Ficou insuficiente.
Ficou insuficiente. E aí, o que eu tinha recomendado para ele à época, ele desistiu, era fazer uma transferência de grande dorsal para tríceps, para ele recuperar essa força de tríceps. Mas, coitado, é um cara que passou por tanta coisa. Que... Bom, o Dr. Paulo colocou uma questão aqui. Seria possível fazer o box loop para essa reconstrução ligamentar, para colocar mais estabilidade nesse cotovelo? O que vocês acham do box loop?
Nesse caso, eu não sei, não indicaria.
Assim, esse caso é bem peculiar, né? Porque era uma rigidez, então não era nem tanta a instabilidade um problema, mesmo após a liberação. Eu fiz a reconstrução lateral, sobretudo porque eu tive que praticamente tirar toda essa parte mole lateral do cotovelo, então achei prudente fazer isso. O Bruno Brandão gosta muito do box loop, né, que foi uma técnica descrita pelo Odrisco, nos casos de instabilidade crônica. Eu não gosto do box loop. Qual que é a opinião de você sobre o box loop? Não nesse cenário, num cenário de instabilidade crônica inveterada.
Eu também não uso, não.
A minha crítica particular ao box loop é a mesma do fixador externo dinâmico, né? A gente percebe que cada vez mais se usa menos o fixador externo dinâmico, exatamente porque é difícil você achar esse centro esse eixo anatômico de rotação do cotovelo lateral e medial, né? E conectar ambos os eixos. O box loop exige a mesma coisa, que você faça praticamente essa conexão do eixo de rotação lateral com o medial. Eu prefiro, quando eu tenho a necessidade de reconstruir ambos os ligamentos, de fazer de forma isolada. Reconstruir o lateral e reconstruir o medial com enxertos separados e não com enxerto único. O Bruno tem outra visão, ele compartilha com a ideia do Odrisco, mas eu prefiro a minha.
Eu particularmente, com relação ao box loops, eu tenho a mesma impressão, Lucas, que eu entendo que, além de você ter a dificuldade de estabelecer o centro de rotação com perfeição para que você possa fazer a estabilização, você não deixa de fragilizar o húmero distal, apesar de que o túnel é um diâmetro pequeno, mas você não deixa de fragilizar essa região de húmero distal. E o tensionamento desse tendão, o tensionamento para você deixá-lo numa situação de permitir uma maior estabilidade e fazer com que você movimente esse cotovelo o mais rápido possível, eu também não me sinto muito seguro.
Pessoal, eu agradeço muito a participação de vocês. Vocês foram muito bem. Acho que está todo mundo de parabéns. São casos que não são fáceis e vocês foram muito bem. Parabéns.
Parabéns.
Luizinho, te agradeço muito, viu?
Desliga
pela ajuda.
Apaga seu share screen aí, por favor. Joia. Maravilha.
Agradeço muito a participação.
Foi um prazer, parceiro. Você sabe o carinho que a gente tem por você, não só como pessoa, mas, obviamente, mais do que isso, o seu conhecimento na área. Eu vou deixar a palavra aí com o nosso presidente da regional, o Fábio Brandão, e com o nosso futuro membro da diretoria, se assim Deus quiser, João Felipe.
Deixa eu iniciar, Luiz. Eu queria agradecer a todos hoje, né? Em especial a Lucas pela nossa moderação, a Marcílio, Tiago e a Dalmolin por terem participado, contribuído com o dia de hoje. Essa data de hoje nossa é uma data um pouco maior. Maior por quê? Devido ao brasileiro, que a gente vai ter agora em novembro, a gente vai ter, então, a impossibilidade de manutenção das nossas reuniões por ausência de data. Então, a gente vai estar finalizando o ano agora da sociedade, no caso da Nordeste, e isso a gente precisa de um agradecimento um pouco mais amplo. Eu acho que a gente fez muito esse ano, tivemos reuniões internacionais com participação da família Morrey, que vocês participaram aqui, mas teve o Atoll, teve conosco, o Tox teve conosco, Samuel Antunes teve conosco, o Jeffrey Abrams também teve conosco, fez com que engrandecesse muito nossas atividades. Mas eles são importantes, mas eu acho que mais importante do que eles foi a participação da gente. Isso tudo aconteceu porque a gente teve um grupo coeso, feito aí por Dr. Luiz Alfredo e Dr. Fábio, que fez com que essas coisas existissem, na verdade. Um agradecimento nacional por ter possibilitado isso, na pessoa do Dr. Luiz Alfredo e Dr. Ikemoto, mas em especial a Kátia e a Murilo, que fizeram uma ajuda, sem eles eu acho que isso aqui não funcionava. Os colegas da Nacional, que também fizeram parte de todas essas nossas reuniões, mas em especial os colegas nossos do Norte Nordeste, que essas reuniões foram feitas para eles e são compostas por eles. Esse ano o Fábio vai estar encerrando os 2 anos dele frente à nossa sociedade, Diogo vai estar assumindo agora para os próximos 2 anos, e a gente tem toda uma programação já para o ano que vem, claro, vai ser isso posto um pouco mais no futuro, mas a gente pretende que isso que a gente conseguiu esse ano possa ser reposto para os anos subsequentes. Eu queria passar a palavra para Fábio, para que ele pudesse encerrar aí hoje, né, Fábio, esse ano aí de sucesso nosso.
Bom, antes de mais nada, obrigado pelas palavras, tá, João? Obrigado a Lucas pela participação de hoje, aos amigos Marcílio, Serpinha, Fábio, Xará, Luiz Alfredo, você é nosso grande parceiro, grande amigo, João também, obrigado pela ajuda. Como o João falou, esse projeto nos orgulha muito. Algumas pessoas podem achar que isso é um projeto para a gente se envaidecer, mas não é. É um comprometimento com a nossa regional. E esse ano tão atípico, acho que a regional se saiu muito bem perante a nacional, perante a SBOT e perante a comunidade internacional também. Então, estamos todos não só a comissão organizadora, mas todos nós membros da SBCOC especial Norte-Nordeste, estamos de parabéns pelo projeto que foi almejado e alcançado esse ano. E aí eu passo a presidência para o Dr. Diogo Rolim para o ano que vem e espero que a gente continue esse projeto científico já de sucesso, se Deus quiser. Obrigado a todos. Luizinho, por favor, Dr. Luiz Alfredo, por favor, encerre o evento.
É porque no off, eu viro e mexo, chamo a atenção desses caras, que eles ficam me chamando de Luizinho. Daqui a pouco o povo não sabe nem quem é Luiz Alfredo Gomes Vieira, pô. Só Luizinho.
É a forma carinhosa, Luizinho.
Luizinho, deixa eu só agradecer a vocês antes de fazer o encerramento. Eu queria agradecer a oportunidade que o Luizinho me convidou ali para participar com vocês. Foi um imenso prazer. E além de tudo, cumprimentar vocês pelo brilhante trabalho que vocês têm feito. Eu vi, Fábio, acompanhando tua gestão, foi muito bem, assim, teve uma repercussão. O mundo virtual possibilitou isso, que todo mundo consiga ter o mesmo espaço. Então, eu acho que vocês aproveitaram muito bem isso e, com certeza, a Regional Norte-Nordeste cresceu muito nesse período. Então, parabéns mesmo pela organização e de todos vocês que estão ali ajudando nessa, o Luizinho ali liderando ali a digitalização e o excelente convite desses participantes internacionais, mostrando o quanto bem a gente está também aqui, né, com a gente discutindo com eles, nós brasileiros ali de igual para igual, aprendendo sempre, mas mostrando o que se faz de bem aqui e que a gente felizmente cresceu muito nos últimos anos, né? Então, parabéns a todos vocês ali e continuem assim.
Faço das minhas palavras, faço das palavras do Fábio das minhas também. Parabéns.
Valeu, Fábio, Lucas, valeu, turma. Eu não preciso mais comentar nada. O João e o Fábio Brandão já fecharam bem o bloco. Eu só tenho muito orgulho de estar fazendo parte dessa parceria com esses amigos queridos, amigos mais antigos, amigos mais novos, mas com a intensidade de carinho tão quanto fosse o mais antigo dos amigos. A amizade a gente acaba desenvolvendo com o passar do tempo, mas muitas vezes Nosso Senhor aponta aquele cara ali e te mostra como um amigo que parece que você conhecia desde pequeno. E assim eu me sinto com muitos de vocês. É muita alegria saber e perceber que o nível dos colegas Norte-Nordeste, mais uma vez eu falo isso, não deixa a desejar a ninguém, porque todos os lugares que os demais vão visitar, nós também vamos. Alguns são mais inibidos, outros são mais soltos, mais tranquilos para falar. Isso é uma característica pessoal de cada um, mas eu fico muito feliz. Eu lembro quando Fábio Dalmolin era presidente da Nacional, que ele foi em Fortaleza para um Norte-Nordeste nosso, e que depois, na confraternização, ele estava me falando o quão impressionado ele estava com o nível de conhecimento do pessoal do Norte-Nordeste. E é o que eu conclamo os colegas Norte-Nordeste que apareçam mais, que trabalhem mais, que divulguem mais, porque só assim a gente consegue mostrar que a gente está no mesmo nível de todo o país, e como o Fábio falou aí, a gente falando e perguntando perguntas muito interessantes para a gente que é referência no mundo. Então, muito obrigado, pessoal, é uma alegria mesmo. Encerramos um ciclo maravilhoso de 2 anos de alta gestão do Fábio, com apoio absoluto do João Felipe. Então, muito bom. Ano que vem, tenho certeza que com o Dioguinho as coisas vão brilhar ainda mais.
Parabéns a todos e obrigado pelo convite. Obrigado, Lucas. Obrigado, Fábio, Brandão.
Obrigado, pessoal.
Valeu, pessoal.
Obrigado, doutor Luiz Alfredo Gomes.
Valeu, parceiro.
Para todos. Um abraço para todos.
Beijo para
todos aí.
Sabadão.
Sábado, agora começou.
Tchau, tchau.
Tchau, tchau.